So I would now request Dr. Sima Das to first present. She'll be speaking on orbital infections. Inflammations, how? Can somebody please give me the program of this event? So, Dr. Sima, please start.
And thank you for. No, it's on. Yeah, it's on, right? Yeah. Thanks for this opportunity, and sorry for this little change in the sequence. I know we are supposed to start with the basic evaluation and the sort of the anatomy part of it, but because I have another commitment. So I will be speaking about orbital inflammation. So inflammatory diseases are something which all of us see, be it oculoplastic surgeon or a general comprehensive ophthalmologist who does cataract also. So we cannot avoid seeing inflammation. And we all know the cardinal signs of inflammation: heat, like increased temperature, redness, swelling, pain, loss of function. These are all the cardinal signs which we have been taught in the pathology books. Now, if you see a couple of cases, this was a young gentleman, 30-year-old, presented with this proptosis, sudden onset, lot of pain, redness, chemosis. All the signs of inflammations are there. Movements are restricted. His vision is also affected. So it's a hot, red, painful orbit with lot of swelling, and function is affected. But what we see on the imaging is a mass lesion which is sitting there in the orbit. So this also presented as an orbital inflammation. He did not respond to the conventional treatment which was given to him, that is steroid, and eventually when we did the biopsy, we know the diagnosis. This was a fungal orbital cellulitis which presented as an orbital inflammation. So these are specific inflammation. Again, another lady presented with this painful red eye, proptosis, loss of function, movement restriction, and mass in the inferior orbit. Biopsy showed liquefactive necrosis with areas of caseous necrosis. She eventually developed areas of limbal thinning, corneal thinning. So this was basically a autoimmune disease with lot of inflammation with necrosis which was happening, and her Cianca was raised. Biopsy showed evidence of necrotizing inflammation, vasculitis, small vessel vasculitis, and we know the diagnosis. This is Wegener's. So inflammation like this are the inflammation with specific causes, like either it could be an infective etiology also which can present with inflammation, that is fungal infection, foreign body granuloma. And then there is a category of idiopathic inflammation with specific histopathology, like we saw in the second patient, like in Wegener's, where the presentation is like any other inflammation, but the histopath is very specific, which gives the diagnosis. And then we have the basket. If these two are ruled out, then the whatever rest inflammation is there goes into the basket of non-specific idiopathic inflammation. So we have to understand that NSOID, non-specific inflammation, is a diagnosis of exclusion. We can't just diagnose or label the patient as NSOID on the first visit based on the signs of inflammation unless we work up the patient to rule out the other specific causes. So NSYD that's the biggest chunk, so I'll be focusing more on that. That's not a single disease entity. It could be like, disease which is involving every orbital tissue, but the unifying feature here is the in a typical case is the abrupt onset of inflammation with a lot of pain, extreme sensitivity to the steroid. They respond to steroid. Imaging is usually very non-specific, showing irregular margins of the tissue, whichever tissue is affected, with a lot of signs of edema within the orbit. But we have to remember that atypical presentations are also possible. So according to the anatomical structures which are present in the orbit, the patterns of presentation could be based on which structure is affected. If the muscles are affected, it becomes a myositis, lacrimal gland dacryoadenitis, anterior inflammation, diffuse inflammation. If the orbital apex is affected, apical, and if that lesion is or the inflammation is predominantly around the optic nerve, it's a perineuritic. And the last variant, which is a very, again, more specific variant, is a sclerosing variant. This young girl comes with history of, her main complaint was double vision. She has some redness. If you see, there is some congestion of the conjunctiva in the right eye, but what is more striking is the movement restriction. So function is affected, there is some pain, there is redness, but it's not a hot, red, swollen orbit. So she doesn't fit into the signs of specific orbital inflammation. So do we still label it as inflammation? So idea here is to highlight that not all inflammations are acute. There can be subacute presentation. This girl had a myositis. We can see the muscle which is thickened, which is irregular edges. So myositis sometimes can present without any signs of overt inflammation, and they do respond to steroid. That is one of the diagnostic indicator again if you don't want to do a biopsy. So we can see after steroid the movement has become better. So it indirectly kind of confirms the diagnosis that it indeed is a myositis. Myositis can be acute or subacute in presentation, could involve one muscles or multiple, can be atypical also, but the unifying feature are the irregular enlargement of the muscle which does not spare the tendon, unlike in thyroid eye disease where usually it's a tendon involvement. This was a gentleman with bilateral multiple muscle involvement. Again, young gentleman, signs of inflammation, everything else is there. What we see is a muscle thickening. But what is striking here is probably the tendon which is spared in this case. So we need to differentiate the cases of idiopathic orbital inflammation from the acute stage of thyroid orbitopathy, where the overlapping features can be there both on imaging as well as clinically. Cysticercosis, very common in our setting, can present like a myositis kind of picture. B-scan or imaging usually gives a diagnosis, and sometimes there can be infiltrative pathology within the muscle, like this gentleman had extraocular muscle lymphoma which presented with signs of inflammation. So we have to be aware of what are the cases where we need biopsy, and we'll be talking about it later. So generally if it's an unilateral typical myositis, which is a single muscle disease, they're usually good prognosis. So conservative treatment with either NSAID or low dose steroid is sufficient. But if it's an atypical presentation, multiple muscle involvement or recurrent course of disease, we need to rule out any systemic cause, and more often than not they will need high dose steroid and sometimes biopsy if it's a recurrent inflammation. Moving on to the next pattern, young lady presented with a typical red hot painful orbit, swelling, function affected, there is ptosis, so that's the function which is affected, and she has an S-shaped lateral drooping of the eyelid, which is almost characteristic of an dacroadenitis, acute dacroadenitis. So prominent, it can involve the orbital lobe or the palpebral lobe. Pouting lacrimal drugs can be visible, and there is a localized congestion and chemosis at the site of the lacrimal gland. So generally, how do we treat dacroadenitis? We go by the function of the gland, and the gland's function is measured by the Schirmer's. If the Schirmer's is affected, that means the gland, lower the Schirmer's is, more is the gland affected. So more intensive is going to be your treatment. So anything less than 5, we generally go for IVMP. If the Schirmer's are somewhere between 5 to 15, oral steroid might be sufficient. If the Schirmer's is preserved and more than 15, even non-steroidal anti-inflammatory might work. This was another lady, subacute presentation, presented like a dacroadenitis based on the imaging finding, but since this was an atypical presentation, did not respond to steroid, we went ahead with biopsy, and what turned out to be was an IgG4 inflammation. This is a relatively new entity which we should be aware of, especially the atypical presentation of dacroadenitis, which is one of the commonest presentation of IgG4 disease, and there are specific criteria to diagnose it. So if on the histopath, if the ratio of IgG4 positive plasma cells versus IgG is more than 40%, or if the serum IgG4 level is raised, then the diagnosis becomes an IgG4 related inflammation. There are very specific criteria and guidelines which are given for the diagnosis. Steroid remains again the mainstay of treatment, and many of them will need immunosuppressants also because these are chronic disease, and sometimes surgical debulking also. Rarely can be bilateral recurrent, but this was little unusual because this gentleman had bilateral dacroadenitis, but the Schirmer's was preserved, which is atypical of a dacroadenitis, idiopathic dacroadenitis. So we went ahead with the biopsy, and what we found was caseating necrosis, and AFB was positive. So this was a tuberculosis infection which presented like a dacroadenitis. So there are a list of differential diagnoses of dacroadenitis: viral, bacterial, autoimmune diseases, sarcoid, tuberculosis, even infiltrative disease like leukemia, lymphoma, which again we should be aware of. And this needs to be ruled out by a biopsy before we label the patient as an idiopathic dacroadenitis if the presentation is atypical. This is the pattern 3, diffuse NSYD. There is a diffuse inflammation of the orbit, but again this can mimic many other pathology. All of this looks like a diffuse NSYD, but the first patient had a caroticocavernous fistula with a corkscrew dilated blood vessels, and we can see the dilated superior ophthalmic vein on imaging. So this is not a non-specific diffuse orbital inflammation. This is a specific cause and needs a specific treatment. Steroids are not going to help cure the disease. Second one was a mass lesion, rhabdomyosarcoma, presented like an orbital inflammation. The third was a venolymphatic malformation with some acute bleed probably, which presented like an orbital inflammation. So these are all the differential diagnoses of NSYD and which we need to be aware of. Moving on to the next pattern, that is orbital apex involvement, that the apical NSYD usually presents like an orbital apex syndrome, and depending on the involvement of the nerve, there can be total ophthalmoplegia, the vision can be affected. There can be mild proptosis, chemosis, depends on the severity of the inflammation. Host of differential diagnoses, including Tolosa syndrome and tuberculosis, Wegener's, all of these can present. This is one entity which is difficult to diagnose on histopath because that's an area of the orbit which we can't diagnose. So we can do a systemic workup if there is a suspicion and give a trial of steroid. If it responds very quickly and a good response, then sometimes that corroborates your diagnosis. The next pattern is the perineuritic, where the inflammation is predominantly limited around the optic nerve, like in young girl, where we can see a lot of inflammation around the sclera and around the optic nerve. So this is a perineuritic pattern of orbital inflammation. Again, after ruling out any other systemic cause like tuberculosis or other granulomatous or autoimmune disease, steroid remains the treatment of choice. Coming on to this gentleman, he has red, painful, swollen orbit, increased temperature, all the signs of inflammations are there, but if you see his imaging, there seems to be a mass lesion with a lot of destruction of the bone, which is again not fitting into the criteria of imaging of orbital inflammation. We hardly see bony changes in idiopathic orbital inflammation. So do we still label it as inflammation? Definitely not a typical inflammation, maybe an atypical inflammation, but this definitely needs a biopsy to rule out other causes. So we did a biopsy, and what we found was the sclerosing, lot of sclerosis with a lot of desmoplastic reaction, dense fibrosis, and very paucicellular infiltrate. All of these are diagnosis of points towards the diagnosis of a sclerosing variant of NSYD. And this is one variant where there can be a lot of bony destruction, and it can mimic a, the tumor or neoplastic etiology. Other DD of this condition could be fungal, sarcoid, Wegener's. There can be bony changes in these entities also, and other metastatic cancer also needs to be ruled out. Again, the treatment remains steroids. Just quickly going into the algorithm, I'll just finish here. If there are typical features, if it's a first episode of inflammation, it's a unilateral disease, there is no systemic evidence of any other cause for the inflammation, we treat this patient with either non-steroidal or low-dose steroid, depending on the severity of the inflammation. Recurrence is very unlikely in a typical case. If it responds, then it's fine, we don't have to do anything else. But if it's a bilateral disease, there is a recurrent disease, or it's an atypical pattern of inflammation like what we saw, or it's a perineuritic inflammation where the optic nerve or the visual function is affected, high-dose steroid is the treatment of choice. So IVMP is the treatment of choice. Many of them will need immunosuppressants depending again on the severity of the inflammation. We need to investigate for systemic disease, keep the patient on a close follow-up, and if it's coming back, typically more than 2 or 3 recurrences per year is an indication for going for biopsy. And if on biopsy we find a specific cause like Wegener's or sarcoidosis or any other cause, we then treat the specific cause for the inflammation. So I think I'll stop here, and thank you very much.
Thank you, Dr. Sima, for an extensive talk. Just one question, just for the benefit of the audience. One is, if you have to take a biopsy, which lobe you should target? And the second is, like many of these patients, as we know, they keep coming back again and again, very dissatisfied that, Yeah. So what should be told to the patients, what kind of counseling should be done before you discharge them?
So generally, if our diagnosis is orbital inflammation, after all the workup and everything, we tell the patient this is one disease where there is a chance of recurrence. So they need to be prepared that, we are treating it. It's not that it will give a complete cure. There are possibilities the disease might come back. And we also tell them on the first go itself, right now we are not doing any biopsy. We are giving you a trial of treatment, response fine. If there is no response, we will go ahead with a biopsy. So they are mentally prepared that, this is part of the treatment which is already planned and not a treatment failure. Sometimes they label it as a treatment failure. Second thing about the biopsy site. So biopsy should be done from, generally if it's a lacrimal gland inflammation, we go by the imaging finding and clinical evidence of which lobe of the gland seems to be more involved. So if it's predominantly the orbital lobe, we biopsy that. If it's predominantly the palpebral lobe, we biopsy both. We usually avoid biopsying the palpebral lobe because that is a lobe which is the, the functional lobe, and damaging the kind of, the ductules can actually end up the patient getting a lot of dry eye. So generally, as much as possible, we avoid biopsying the palpebral lobe, and more often than not, it will be the orbital lobe which will be involved, which will need biopsy. These are the atypical cases. Generally, the palpebral lobe involvement are in the typical dichroadenitis who usually responds well to steroid.
Dr. Sima, so when the patient has the recurrence, and is already on steroids, so you have to discontinue steroids. For
Yes.
how long period you take a gap?
Preferably
And
6
because
weeks.
the symptoms will be
possible.
increasing in
Correct.
those
Yeah.
periods.
So preferably 6 weeks if the symptoms are not so severe and the patient can tolerate it. But if not possible, then at least for 2 weeks. So we discontinue the steroid before we go for biopsy. Otherwise, we might miss the findings. The findings can be masked because of the steroid.
So thank you so much, Dr. Sima.